Welcome to our third and last video on Acyanotic congenital heart diseases. Let's begin. These are the topics we're going to discuss in this lecture. Let's start with patent ductus arteriosus. On each of these topics, we will be discussing the introduction, clinical presentation, diagnosis, treatment, and complications. It occurs due to the failure of spontaneous closure of ductus arteriosus postnatally. In normal infants, functional closure occurs within 18 to 24 hours. It is mostly associated with prematurity and congenital rubella syndrome. Here is an illustration showing patent ductus arteriosus, which connects aorta with the left pulmonary artery. This leads to left-to-right shunt. PDA can be asymptomatic if it is small. However, larger defects can manifest with irritability, growth failure, and exercise intolerance. If it is not repaired, Eisenmenger syndrome can result, which is characterized here by differential cyanosis. This means that lower extremities are cyanosed while upper extremities are not. We have few important clues to identify PDA on physical examination. They are bounding pulses, wide pulse pressure, and a loud, machine-like continuous murmur best heard at the left infraclavicular area. Cyanotic modalities are similar to other congenital heart conditions. Chest X-ray reveals cardiomegaly along with prominent pulmonary artery. ECG may show left axis deviation consistent with left ventricular hypertrophy in large defects. Lastly, echocardiography is the most accurate test which evaluates pulmonary artery pressure and volume of the shunted blood. Treatment can be limited to conservative management or can require surgery. Conservative management is for small PDA with absence of left heart volume overload. Usually, indomethacin is prescribed for the closure of patent ductus arteriosus unless patency is required for the survival of other heart conditions like tetralogy of Fallot. Surgical closure or percutaneous catheter occlusion can be performed for the child with failure of pharmacologic therapy and the child on maximal ventilator support. Complications include infective endocarditis, pulmonary hypertension, and heart failure. Let's briefly discuss pulmonic valve stenosis. It is defined as the stenosis of the pulmonic valve leading to right ventricular outflow obstruction. It is an isolated congenital defect without any well-known association. Here's an illustration showing pulmonary valve stenosis leading to right ventricular outflow obstruction. Clinical presentation is variable and depends on severity of stenosis. It can be asymptomatic. However, when it is symptomatic, the patient complains of dyspnea and angina. Clinical clues include a crescendo-decrescendo systolic murmur heard at second left intercostal space, which increases on inspiration. Also, wide splitting of second heart sound is evident. This is explained by the prolonged pulmonic ejection. Chest X-ray may show postnatally dilation of pulmonary artery. An ECG shows right axis deviation consistent with right ventricular hypertrophy. Echocardiography is the most accurate test, which helps to evaluate the grade of stenosis. No treatment is required for the mild cases. If required, percutaneous balloon pulmonary valvuloplasty can be done to relieve the stenosis. Surgery is reserved for some critical cases and the child with multiple heart defects. Complications include infective endocarditis and heart failure. Let's do a review question. A 7-year-old boy is brought to the physician by his parents due to bilateral leg swelling for the past 2 weeks. He was born with a congenital cardiac defect. Physical examination reveals 1+ pitting edema in the lower extremities. The cardiac auscultation shows crescendo-decrescendo systolic murmur at the left second intercostal space along with wide splitting of S2. What is the most likely diagnosis? This young boy presents with 1+ pitting edema in the lower extremities. He was born with a congenital heart defect which most likely accounts for his edema. The cardiac auscultation shows crescendo-decrescendo systolic murmur at the left second intercostal space along with wide splitting of S2. Left second intercostal space is the pulmonic area. Therefore, this patient likely has a defect of the pulmonic valve. Given the systolic crescendo-decrescendo murmur and wide splitting of S2, the patient most likely has the congenital pulmonic valve stenosis. Let's end our lecture with a board-style question. A 10-year-old girl is brought to the physician due to easy fatigability. She joined the school runners team, but she cannot keep up with her peers due to severe leg cramps while running. Her vital signs include a temperature of 36 degrees Celsius, a blood pressure of 110/40, a heart rate of 75, and a respiratory rate of 16. The physical exam shows bounding radial pulse and harsh murmur throughout the cardiac cycle best heard at the left infraclavicular area. Which of the following is the most likely diagnosis in this patient? A. Coarctation of the aorta. B. Patent ductus arteriosus. C. Ventricular septal defect. Or D. Atrial septal defect. This young girl presents with easy fatigability. She joined the school runners team, but she cannot keep up with her peers due to severe leg cramps while running. Her vital signs are significant for a wide pulse pressure of 70. Let's recall that the pulse pressure is the difference between systolic and diastolic blood pressures. This patient's systolic blood pressure is 110, while diastolic blood pressure is 40. So the pulse pressure would be 70. The physical examination shows bounding radial pulses and the harsh murmur throughout the cardiac cycle, best heard at the left infraclavicular area. Wide pulse pressure, bounding pulse, and a continuous murmur, best heard at the left infraclavicular area, are consistent with the patent ductus arteriosus. Therefore, the correct answer is option B. Here's a slide reminding us of the clinical presentation of patent ductus arteriosus. Let's discuss why other options are incorrect. Option A is incorrect because coarctation of the aorta is associated with the systolic ejection murmur at the left interscapular rather than infraclavicular area. Option C is incorrect because ventricular septal defect is usually not associated with leg claudication. Additionally, ventricular septal defect causes the holosystolic murmur at the left sternal border. Finally, option D is incorrect because atrial septal defect is typically not associated with leg claudication. Also, it causes fixed splitting of S2, which is absent in this patient. And that concludes our lecture on acyanotic congenital heart diseases.